the coming 1 hour, I will discuss the topic of rhinosinusitis. The first segment of this lecture will be dealing with the issue of acute rhinosinusitis. What is acute rhinosinusitis? It is acute inflammation of the paranasal sinuses, extending usually less than 4 weeks. Just a quick hint about the anatomy of the sinuses. On this coronal CT scan taken at about the mid-orbital level, the paranasal sinuses are air-filled spaces surrounding the nasal cavity and communicating with the nasal cavity. What we can see on this CT scan is the maxillary sinus, the anterior ethmoids, and if we go more anterior, you will start to see the frontal sinus. The frontal sinus, together with the maxillary sinus and the anterior ethmoids, comprise the anterior group of the paranasal sinuses that drain collectively into the middle meatus. More posteriorly, we can see the posterior ethmoids that drain into the superior meatus under the superior turbinate. More posteriorly, we can see the sphenoid sinus, which drains into a space in the most posterior part of the nasal cavity that is termed the sphenoethmoidal. This is the sphenoid, this is the posterior ethmoid, and this space in front of the front face of the sphenoid is the sphenoethmoidal recess. Coming back to acute rhinosinusitis, how does infection spread to the paranasal sinuses? The commonest route of spread of infection to the sinuses is from the nasal cavity, from the nose, that's to say rhinogenic, and this comprises 80% of cases. In 10% of cases, the infection can reach the sinuses from the teeth, that's to say dental, and this comprises another 10% of cases. The last group of infection can result from trauma to the nose and paranasal sinuses, and this comprises 10% of cases. As I already mentioned, 80% of infections reach the paranasal sinuses from the nasal cavity, and this can occur following an attack of acute viral rhinitis. Another 10%, the infection can come from the teeth, as we can see here in this patient with periapical abscess. Infection has started in the maxillary sinus, and here the source of infection is from the teeth. Sometimes sinusitis of dental origin arises following dental manipulations, as in this case, this patient had dental extraction, which was complicated by driving part of the root of the tooth into the sinus, and we can see swelling of the adjacent mucosa. Here, the infection starts in the maxillary sinus so long that there is a foreign body, which is a broken root in the sinus, and in order to help resolve the infection in such a situation, the broken fragment should be taken out, as we can see in this clip. This is the broken root that started the infection. What about the microbiology of acute rhinosinusitis? The commonest is bacterial, and in the commonest group of pathogens that cause acute rhinosinusitis, we can find that strep pneumoniae, Haemophilus influenza, and Moraxella catarrhalis are the commonest pathogens. In sinusitis of dental origin, anaerobic organisms are usually the underlying pathogen. Very rarely, fungal acute rhinosinusitis can occur. This usually occurs in immunocompromised patients, and the disease runs a short fatal course, and it is labeled mucormycosis. What about the clinical picture of acute rhinosinusitis? The clinical picture of acute rhinosinusitis, it usually occurs few days after developing an attack of common cold. The patient complains of fever, nasal obstruction, mucopurulent or purulent nasal discharge, pain or headache. This pain or headache characteristically increases on coughing or bending. The patient may localize the pain at the region of the inner canthus when it is of ethmoidal origin, or it could be felt over the cheek in maxillary sinusitis, sometimes referred to the teeth or ears, or the pain may be perceived over the forehead in case of frontal sinusitis, or the pain may be felt behind the eyes in sphenoiditis. On examination, there is congestion of the nasal mucosa, as we can see in this endoscopic picture of the right nasal cavity, middle turbinate, septum, middle meatus, lateral nasal wall. We can observe the nasal mucosa to be fiery red in color, as well as obvious swelling of the nasal mucosa. There is tenderness over the involved sinuses, and the hallmark of the examination is the presence of mucopurulent discharge in the nasal cavity or in the meatai. Usually, investigations are not requested in acute rhinosinusitis, and the diagnosis is made based on history and examination findings. If the history and the examination findings are inconclusive, then at this point investigations may be requested in the form of a CT scan. If there is discharge in the nose, we can take a swab for culture and sensitivity, and occasionally we may request a complete blood count. How to treat a patient with acute rhinosinusitis? Treatment includes rest, appropriate antibiotic therapy for 10 days, analgesics, decongestants, local hot applications, and if the patient has an obvious dental septic focus, the patient should be sent to a dentist to eradicate any dental septic foci. Moving on to the second segment of this lecture, which is chronic rhinosinusitis. Chronic rhinosinusitis is a chronic inflammation of the paranasal sinuses lasting more than 12 weeks. It is a disease of multifactorial etiology. What are the factors that can contribute to the genesis of chronic rhinosinusitis? The first is the persistence of the so-called predisposing factors. Second is inadequate treatment. The third, inadequate treatment of an acute attack. The third is high virulence of the organism. Number 4 is the low resistance of the patient. It's very important to be able to identify the predisposing factors that can lead to chronic rhinosinusitis and to be acquainted with these predisposing factors. So what are the predisposing factors? Predisposing factors could be either general or local. The general predisposing factors include, number 1, allergic rhinitis, exposure to dust, fumes, smoking, and environmental pollution. Number 3, diminished immunity, which include any conditions that may compromise the immunity of an individual, such as diabetes, uremia, HIV infection. Lastly, diseases affecting mucociliary clearance activity, such as primary ciliary dyskinesia and cystic fibrosis. What about the local predisposing factors? The local predisposing factors include ethmoiditis or anatomic abnormalities in the ethmoids, sinonasal conditions such as deviated septum, polyps or tumors, nasopharyngeal conditions such as choanal atresia and adenoids, dental conditions such as septic teeth. What about the clinical picture of chronic rhinosinusitis? Patient may complain of one or more of the following: nasal obstruction, nasal or postnasal discharge, pain or headache, smell disorders, recurrent respiratory infections, and cough. Every patient presenting with possible diagnosis of chronic rhinosinusitis should undergo 3 basic investigations. The first is nasal endoscopy, the second is a CT scan, the third is culture and sensitivity of any discharge in the nasal cavity. Nasal endoscopy is usually conducted under topical anesthesia in the outpatient as the patient is undergoing a general ENT examination. We use this version of endoscopes, a rigid endoscope about 18 centimeter length and 4 millimeter thick. As already mentioned, the examination is done in the outpatient, sometimes without any form of anesthesia, sometimes with topical anesthesia. It is usually well tolerated by the patient and is quite informative. This is an endoscopic picture of the same patient we saw in the previous slide. Here we are in the left nasal cavity, the nasal septum, the middle turbinate. Here we can see mucopurulent discharge coming out of the middle meatus, indicating an inflammatory process in the anterior group of sinuses in this patient. During the examination, we can see some of the predisposing factor, such as here we can see a deviated septum impinging on the middle turbinate and the entrance to the left middle meatus. Sometimes during the examination we can see predisposing factors, such as in this situation we are examining the right nasal cavity and I'm approaching the choana. We can see this huge adenoids blocking the choana and acts as a predisposing factor for chronic rhinosinusitis in this patient. Here we are removing this adenoid using a shaver. Once we have done the endoscopic examination, the patient undergoes the second investigation, which is a CT scan, which shows the opacity within the maxillary as well as in the ethmoids of the same patient. So the radiologic imaging complements our endoscopic examination in mapping the disease and confirming the diagnosis of chronic rhinosinusitis. The third investigation is whenever we're having mucopurulent or purulent discharge in the nose in a patient with chronic rhinosinusitis. Here we take a swab from this discharge using this malleable swab, and we send it for culture and sensitivity study so as to use culture-directed antibiotic therapy in these patients. What about the treatment of a patient with chronic rhinosinusitis? Treatment is usually initially conservative. We eliminate any predisposing factor that may have contributed to the disease. For example, if the patient is having uncontrolled allergic rhinitis, he should undergo allergy treatment. If the patient has septic teeth, he needs to get these septic teeth managed. If the patient has adenoids, this adenoid needs to be removed. The next step is to prescribe medical treatment, which may include antibiotic. Here the antibiotics should be culture directed. Sometimes an antihistamine or topical steroid are prescribed. Occasionally short bursts of systemic steroids are given, and in all instances the medical treatment is very much tailored on the patient history as well as the endoscopic examination. By doing so, elimination of the predisposing factor and giving the patient medical treatment, significant number of patients are usually controlled or cured with this conservative management. In patients not responding to the previous lines of treatment and showing disease in their ethmoids, surgical treatment may be resorted to, and here the surgical treatment, the procedure is called functional endoscopic sinus surgery. The idea of the functional endoscopic sinus surgery is to remove disease from the region of the maxillary sinus ostium as well as in the anterior ethmoids, and without touching the mucosa within the maxillary sinus, by removing the disease in the region of the maxillary sinus ostium as well as in the ethmoids, spontaneous recovery of the disease within the maxillary sinus is usually witnessed over weeks after surgery. Moving to the last segment of this lecture, which is the complications of rhinosinusitis. Complications of rhinosinusitis can occur de novo, that's to say on top of acute, or they can occur on top of patients with chronic disease. The disease or the complications could be either cranial, intracranial, or extracranial. The cranial complications are further stratified into sinonasal complications, which include osteitis, osteomyelitis, and Pott's-Puffy tumor, periorbital and frontal fistulae, mucocele and pyocele. The sinonasal complications are usually more encountered as they relate to the frontal sinus. The second group of cranial complications are the orbital complications. These occur more in children. The patient can present with eyelid abscess, orbital cellulitis, subperiosteal abscess, orbital abscess, and optic neuritis. Ear complications in the form of Eustachian tube dysfunction and otitis media. The second group of complications are the intracranial, and these include meningeal involvement complications in the form of meningitis, extradural abscess, subdural abscess, brain involvement in the form of encephalitis or brain abscess, and if brain abscess occurs, it's usually located in the frontal lobe of the brain. The last category of intracranial complications are venous sinus involvement in the form of superior sagittal sinus thrombosis and cavernous sinus thrombosis. The last group of complications are the extracranial. These could be in the form of ascending and descending infections, septicemia, and pyemia. Thank you.